Okay, think about this for a second. The last time you got, important information, maybe about your health,
Yeah.
did it actually stick?
Yeah.
Did you feel like totally confident
Hmm.
about what you had to do next? For us as nurses, that moment, that handoff of knowledge, the teaching part,
Yeah.
it's just so critical. It's not just giving out facts. It's really about empowering people.
Exactly. And that's really what we're going to dig into today. Our sources, especially this foundational chapter from Lewis's Medical Surgical Nursing, lay out the core principles for teaching patients and their caregivers.
Mhm.
It's absolutely a cornerstone of quality care. And our mission really is to sort of distill this whole process down into something clear, something actionable, packed with insights you can actually use.
Yeah, so we're going to explore the why behind it and also the practical how. Understanding the learner, building effective plans, knowing if you've actually succeeded. We'll touch on things like adult learning, how people change behaviors, communication skills, and adapting everything for all the different patient needs we see.
You know what really struck me in this material was how it emphasizes teaching isn't just like telling someone what to do.
Right.
It's this dynamic, interactive thing designed to shift knowledge, maybe behavior, or even attitudes, all to improve health. So what are the big goals here? What are we aiming for?
Well, at its heart, it's really about empowerment. We want to promote health, prevent disease, help people manage illness effectively, and crucially, make sure they can make informed choices about their own care.
Okay.
And when teaching actually works, it's incredibly powerful. It can prevent complications. It can speed up recovery. It helps people build those self-care skills. The data is pretty clear on this. Patients who really understand and can manage their health, they're just far less likely to bounce back into the hospital. And think about this statistic. 6 out of 10 adults in the U.S. have a chronic disease. 4 out of 10 have 2 or more.
Wow.
So the sheer number of people needing to manage their health day to day, effective teaching isn't just, nice to have, it's a public health necessity.
So given that huge impact, does this mean every single time we talk to a patient, we need some formal sit-down lesson plan all written out?
Oh, not at all. No. While those formal teaching plans are definitely vital for specific, maybe complex learning needs, the sources really highlight that every single interaction you have with a patient or a caregiver is a potential teachable moment.
Okay, like grabbing those opportunities.
Exactly. It's this ongoing responsibility that you, as the nurse, you really can't delegate it. So, for instance, just showing a patient with asthma how to use their peak flow meter, that's teaching, even if it's not some big formal class. Now, when a specific structured learning need pops up, that's when a formal teaching plan is key. It gives you that structure.
Yeah.
Assess what they need, and if they're ready, set clear goals together, implement your strategies, and then this is critical check that they actually learned it.
That makes perfect sense.
Cool.
Okay, building on that, let's talk about the learner. Because teaching adults, it's so different from teaching kids, isn't it?
Oh, absolutely.
What are those core principles for adult learning we absolutely have to keep in mind?
Knowles' principles of adult learning and andragogy, they really boil down to 2 main ideas: relevance and self-direction.
Relevance and self-direction.
Okay. Adults need to know why. Why does this specific information matter to me right now? And they need to feel some control over how they learn it. If they don't see that immediate benefit, or if they don't feel respected in the process, well, you're already starting behind.
Yeah, fighting an uphill battle.
Exactly. Think about a patient, say, just recovering from a TIA that's a transient ischemic attack. They are suddenly very motivated to learn about reducing stroke risk because the threat feels immediate and personal.
Right. It hits home.
It hits home. They're ready because it directly impacts their future. And we should always try to tap into their past experiences, too. If they've managed other health stuff before, you can leverage that confidence.
I can definitely see how knowing that helps tailor the approach.
Yeah.
But what happens when you've got someone who maybe they know all this, they know they should change, but they're just not quite ready?
Yeah, this is a huge challenge we face all the time. It helps to think of health behavior change more like a journey, not like flipping a switch. The trans-theoretical model Prochaska and Valisser developed this. It gives us a kind of roadmap. It outlines 6 stages. Patients can be anywhere on this map.
6 stages. Okay.
Right, from pre-contemplation, where they're not even thinking about changing. Like, imagine a smoker in the hospital who just doesn't see smoking as a problem for them right now.
Yeah, denial maybe?
Or just not on their radar. All the way to action, where they're actively making changes. And our role as nurses, it shifts dramatically depending on the stage.
How so?
Well, in pre-contemplation, maybe we just gently plant a seed, increase awareness. In the contemplation stage, where they're kind of back and forth, ambivalent, I know I should, but We help them weigh the pros and cons.
Let them find their own why.
Exactly. Find their internal motivators. Then when they move into preparation, we help them plan, set priorities. In action, we cheerlead, basically. Celebrate the small wins and, importantly, help them plan for setbacks or relapses, because those are totally normal.
Right, relapse is part of it.
It often is. And this whole model, it really underpins motivational interviewing, which is a technique. It's non-confrontational. It's about listening deeply, showing empathy, and helping patients discover their own reasons for change, helping them see the gap, between where they are now and where they want to be, instead of us just telling them what to do.
Okay, so if we understand the learner, we understand these stages of change. The next piece is us, the teacher. What are the biggest skills nurses need to really hone for effective patient teaching, according to these sources?
Two things really stand out as critical competencies. First, unsurprisingly, is knowledge of the subject matter.
Makes sense.
You need to feel confident explaining what a condition like hypertension is, why treatment is so important, and how to manage it, diet, exercise, meds. But here's the thing. You don't have to be the world expert on absolutely everything.
That's a relief.
Right. It's also about knowing where to find reliable answers and pointing patients towards credible resources, like, say, the American Heart Association website.
Okay, knowledge is one. What's the other key skill?
Effective communication skills. And this is huge. Medical jargon. It's intimidating. It builds walls we have to translate.
Yeah.
So leukopenia, for example, we just need to say, it means you don't have enough white blood cells right now, and those are the cells that fight infection. Simple, clear.
And it's not just words, right?
Oh, absolutely not. Communication is so much more than words. We have to pay attention to nonverbal cues. And typical Western culture, an open, relaxed posture, sitting at eye level, that usually helps build rapport. But we have to be mindful of cultural variation.
Like eye contact.
Exactly. In some Eastern cultures, direct eye contact might be less comfortable, or they might prefer communication through a family spokesperson. And, crucially, active listening, really hearing them and showing empathy, that builds trust. And trust is the foundation. Patients won't learn if they don't trust you.
Spot on. But okay, let's be real. The hospital floor, the clinic, it's not always the ideal teaching environment.
Right.
What are some of those common pitfalls, the barriers that get in the way?
Yeah, the sources list a few that will sound very familiar to anyone in practice. Number one is probably the lack of time.
Always.
Always. Our physical assessments, charting, meds, it all competes with teaching time. The strategy there really has to be set clear priorities. What must they know before they leave? And seize every little opportunity. Reinforce small bits of info during every interaction.
Okay, time is one. What else?
Another is our own feelings as teachers. It's actually really common to feel insecure about your knowledge, especially early on. But teaching is a skill. It develops with practice. You get better.
That's encouraging.
It is. Then there are sometimes differences in learning goals. Our discharge checklist might not match what the patient is actually worried about right now.
Yeah, like they're focused on pain and we're trying to teach wound care.
Exactly. So you need realistic, honest conversations. Sometimes you have to address their immediate concern or even their underlying acceptance of the condition before any other teaching can even happen. And finally, a big one these days, rapid or early discharge.
Shorter stays.
Shorter stays mean we have less time. So we have to start teaching almost immediately after admission. Focus on the absolute must-know, high-priority stuff, and make solid plans for follow-up teaching after they leave.
And it's clear, thinking about discharge, it's often not just the patient going home alone. There's usually someone else involved.
Absolutely. Caregivers, they are so essential. They're often providing direct, hands-on care, but also emotional support, social, spiritual, financial help, navigating the whole healthcare maze.
It's a huge role.
It's massive. Did you know about 1 in 4 American adults acts as a caregiver? So it's vital that we identify who these key people are and then proactively assess their needs too. Because if the caregiver's needs aren't met, if they're overwhelmed or lack skills, they can't effectively help the patient.
So how do we assess their needs?
Simple questions, really. Things like, how are you coping with this? Or what kind of help or services do you need right now? Just opening that door can uncover critical barriers we need to address.
And I imagine cultural things come into play here again, which can add another layer of complexity.
Yes, profoundly. In some cultures, like we mentioned, maybe a male family member is the designated spokesperson. That's fine. But we have to make sure the person actually doing the hands-on care, maybe it's a daughter or spouse, is also included in the teaching and planning.
Right. Get the right people in the room.
Exactly. And what's also fascinating and sometimes tricky is when the patient and the caregiver have different needs, or even conflicting ones.
Oh, like how?
Well, imagine a patient who's been taught how to feed themselves after a stroke, but their caregiver finds it quicker and easier to just feed them. Or the patient is worried about pain with transfers, but the caregiver is totally focused on learning the dressing change technique. We have to see the patient's needs, yes, but within the whole context of the caregiver's reality and their abilities,
Hmm.
and then trying to align those goals. Now, before we really dive into the how-to of teaching plans, it's super important to remember. Patient teaching isn't just, good nursing practice. It's actually a mandated right.
Oh, right. Regulatory bodies.
Exactly. Organizations like the Joint Commission, the American Hospital Association, they ensure patients have a fundamental right to get information about their care that they can understand.
Mhm.
Initiatives like TJC's Speak Up campaign actively encourage patients to ask questions, pay attention, educate themselves. And there's also the Ask Me 3 program.
Yes, me three.
Yeah, it encourages patients to always ask 3 specific questions. What is my main problem? What do I need to do? And why is it important for me to do this? These aren't just slogans, they're practical tools to empower patients to take an active role.
That really is empowering for patients.
Mhm.
Okay, so knowing that it's expected, it's mandated,
Mm-hmm.
how do we actually start the teaching process itself? You said it parallels the nursing process, so assessment first.
Exactly right. Just like ADPIE in nursing, effective teaching starts with a thorough assessment. We absolutely have to figure out, what does the patient already know? How do they see their health problem? What are their most pressing learning needs right now?
And not just the patient, right? You mentioned caregivers.
Absolutely. Caregivers have to be part of this assessment. What's their role going to be? What are their learning needs? What are their capabilities and limitations? It's all about finding that true starting line before we even think about planning the teaching.
Okay, let's talk about common traps in assessment. Physically, like it's easy to forget that if someone's in a lot of pain or just exhausted, learning goes out the window, doesn't it?
Oh, completely. You hit the nail on the head. Unmanaged pain, fatigue, even certain medications like opioids or sedatives that cause CNS depression, central nervous system depression, they just shut down the ability to learn.
So you got to manage those
I
first.
have to. If someone's hurting or wiped out, teaching is pointless at that moment. You also have to consider their age, any underlying conditions that might affect learning, sensory issues like vision or hearing. Can they physically do the skill? Like someone with bad arthritis might struggle with insulin injections unless we find adaptive tools.
So it's not just ticking boxes, it's about adapting the plan.
Exactly. Adjust the plan. Focus on the absolute priorities. Maybe break it down to smaller chunks. Arrange for follow-up teaching.
Okay, beyond the physical stuff,
Yeah.
the patient's emotional state, their mindset, that can be a huge barrier, right? Or sometimes maybe even help.
Definitely. Psychologic factors are critical. Anxiety and depression. Super common responses to being sick. Now, interestingly, a mild level of anxiety can actually sharpen focus, maybe improve learning a bit.
Oh, really?
Yeah, but once it gets to moderate or severe anxiety, it shuts learning down. Limits concentration, makes it hard to retain info. Patients might also be using defense mechanisms like denial. If someone is flat out denying their cancer diagnosis, they're not going to absorb information about chemotherapy, are they?
No, absolutely not. So what can we do?
A key strategy here is building self-efficacy. That's simply the patient's belief in their own ability to succeed at a task, like managing their diabetes.
So building their confidence.
Precisely. You start small, set easily achievable goals first, let them experience success. That builds momentum and confidence for tackling harder things later.
Okay, this often connects to something we hear tons about now.
Yep.
Health literacy. How big of a deal is this really as a sociocultural factor?
It is a massive deal. Health literacy is just the basic ability to get, understand, and use health information to make good decisions. And the stats are kind of staggering. Nearly 90% of U.S. adults have limited health literacy.
90%. Wow.
It's huge. And here's the kicker. We, as healthcare providers, often overestimate how well our patients understand. We think they get it, but they don't. And that directly leads to poorer health outcomes, medication errors, hospital readmissions.
So how do we know? How do we assess it?
Well, we really should assess it routinely. There's a simple tool called the Single Item Literacy Screener, the SILS. It just asks one question. How often do you need to have someone help you when you read instructions, pamphlets, or other written material from your doctor or pharmacy?
Just one question.
Just one. And based on their answer, always, often, sometimes, rarely, never, it gives you a quick gauge. But honestly, the best approach is universal precautions.
Like of infections.
Sort of, yeah. Assume that every patient might have difficulty understanding health information, regardless of how educated they seem. So tailor your teaching. Use their primary language, get a medical interpreter, not a family member, for privacy and accuracy. Provide written materials at maybe a 5th grade reading level. Use simple words, short sentences, lots of pictures or diagrams.
That makes sense. Assume everyone needs it simple and clear.
Yeah.
What about like broader cultural stuff
Yeah.
or socioeconomic status?
Huge impact. Cultural beliefs. They profoundly influence health practices, what people believe causes illness, what treatments they'll accept. We have to ask patients about their beliefs, gently explore if any traditions might conflict with the medical plan.
Could you give an example?
Sure. Maybe in a particular culture, being heavier is seen as a sign of health and prosperity. That could make teaching about diet changes for blood pressure control much harder, right?
Yeah, definitely.
And socioeconomic factors matter too. Knowing someone's occupation might help you choose analogies they'll understand. An auto mechanic. Maybe explaining heart failure as being like a flooded engine resonates better. And practical things, their living situation, do they have electricity, a phone? These all influence what's actually feasible for them to do at home.
Okay, so we've looked at physical, psychologic, sociocultural factors. What about factors specific to the learner themselves?
Right, so this is where we really focus on their specific learning needs right now. What do they think is most important to learn, especially for adults? Asking them to prioritize is key, rather than us just dictating the agenda.
Let them have some control.
Exactly, back to that self-direction principle. We also need to figure out their preferred learning style. Are they visual? Do they learn best by reading, looking at pictures, auditory by listening, or physical kinesthetic by actually doing things hands-on?
Most people are probably a mix, right?
Most are, yeah. So using a variety of methods is usually best. And in today's world, we also need to check their e-health literacy. How comfortable are they finding in using health information online? Using apps, patient portals, maybe telehealth? That's becoming increasingly important.
Okay, so after all that assessment, we finally get to planning. The source really stresses setting clear, measurable, actionable goals.
Absolutely. Vague goals are useless. A good learning goal needs to answer 4 specific questions.
4 questions.
Okay.
1, who is going to do the activity? Is it the patient, the caregiver? 2, what is the actual behavior we want to see? Like list symptoms, demonstrate injection technique. 3, under what conditions will they do it? Maybe in front of the nurse using sterile technique. And 4, what are the criteria for success? Like with 100% accuracy before discharge.
So super specific.
Yes, specific. Avoid wishy-washy verbs like understand or appreciate. Use action verbs. Identify, demonstrate, describe, list. So instead of just saying the patient will understand their colostomy care.
The much better goal is the patient will describe to the nurse the basic steps for changing the colostomy pouch and skin barrier by the day of discharge. See the difference? It's concrete, measurable.
Yeah, that's much clearer. You know exactly what you're looking for. So with those clear goals, how do we pick the best teaching strategies? It can't be one size fits all.
Definitely not. The strategies you choose depend heavily on the patient, what you're teaching, and what resources you actually have available.
Right.
We can use active discussion. This is great for exploring feelings, attitudes, and using that teach-back method we'll talk more about. Lecture discussion is okay for basic info, but you have to follow it up with questions and interaction. For physical skills, demonstration and return demonstration show back is essential. You show them, then they show you. Like changing a dressing or using an inhaler.
Show me. Tell me. Involve me.
Exactly. And we need to use diverse teaching resources. Videos, pamphlets, simple ones, models, apps, reliable websites. Mix it up. Interestingly, the source even breaks down strategies by generation. Like Gen Z might prefer quick videos and hands-on tech, while baby boomers might prefer lecture and printed handouts.
That's interesting. And what about adapting for patients with, say, specific disabilities or cognitive challenges?
Yeah, that's where tailoring becomes absolutely critical. The assessment guides us here. For someone with hearing loss, sit facing them at eye level, speak slowly, clearly, reduce background noise, use visual aids, consider interpreters if needed.
Okay.
Limited manual dexterity, maybe they need adaptive devices like an insulin pen instead of a vial and syringe. Mild cognitive impairment, keep it super simple, 1 instruction at a time. Use yes/no questions, be patient. Repeat and reinforce frequently.
Vision loss.
Vision loss, yeah. Use magnifiers, screen readers maybe.
Mm-hmm.
Make sure print materials are large print, high contrast. Good lighting is key. Focus on verbal instructions, tactile learning, letting them feel the equipment. The general rule is simplify, adapt the environment, use multiple senses, and always aim for that 5th grade reading level in written stuff.
And technology.
Use it. But guide them. Help patients figure out which websites are reliable, like government sites, NIH, CDC, major health organizations, American Art Association, American Diabetes Association. Teach them how to evaluate online info, and telehealth is booming. Remote consults monitor. That's a huge teaching platform now, too.
Okay, so we've assessed thoroughly, we've planned meticulously with clear goals and strategies. Now it's time to actually do the teaching, implementation. What's crucial here to make it stick?
During implementation, you're putting those plans into action. But it's not just reciting information. You got to bring those communication skills, verbal, nonverbal, active listening, empathy. Involve the caregivers appropriately, and always, always circle back to those adult learning principles.
Relevance and self-direction.
Exactly. Respect their autonomy. Avoid talking down to them. Positive reinforcement is good, but make sure it's genuine and adult appropriate. Acknowledge their effort and progress. And remember our patient in pain. If you didn't address the barrier first, the implementation won't work. You teach when they're ready and able to learn.
Right. And then the final step, maybe the most important for knowing if any of this actually worked, evaluation.
Absolutely critical. Evaluation isn't just an afterthought. It tells you if the patient actually met the learning goals you set together.
So how do we evaluate effectively?
Several ways. Direct observation is key for skills. That's the show back. Can they actually administer that injection correctly? Watch them do it. You also observe their verbal and nonverbal cues. Are they asking you to repeat things constantly? Avoiding eye contact, getting restless? Those are clues they might not be getting it. A really powerful technique is asking open-ended questions and using teach back.
Okay, explain teach back.
Instead of asking a closed-ended question like, do you understand, which usually just gets a yes, even if they don't.
Right.
You ask them to explain it back to you in their own words. Okay, so we talked about changing the dressing. Can you tell me how often you need to do that? Or what will you do if you start having chest pain when you get home? It verifies their understanding much more reliably.
And ask the caregiver too.
Definitely. Ask the caregiver for their teach back as well, especially if they'll be involved in the care. And don't forget the patient's own self-evaluation. Ask them how confident they feel, what parts are still fuzzy.
And if the goals aren't met?
Then the process loops back, you reassess, why didn't they get it? Was the goal unrealistic? Was the strategy wrong? Did a new barrier pop up? You revise the plan and try again. It's iterative. And remember, evaluation often needs to happen over time, maybe with follow-up calls or visits after discharge. And finally, document everything.
Yes, if it wasn't documented.
It wasn't done. Document the goals, the strategies used, how you evaluated learning, and what the outcome was. It's essential communication for the whole team.
Okay, let's try to pull all these pieces together with a couple of clinical examples from the source material. First, there was that check your practice bit about the 53-year-old man. Type 1 diabetes for 32 years, admitted with high blood sugar.
Yeah, that one's fascinating. He's stable, ready for discharge. He's had diabetes for decades. But when the nurse asks him to show back preparing his insulin, he draws up 30 units of insulin and 10 units of air instead of the 40 units of insulin he needed.
After 32 years. Wow.
Right. It immediately makes you think, okay, what's going on here? Is it new vision loss? Maybe some mild cognitive changes starting? Is he just stressed out from being in the hospital and rushing? Or maybe his confidence, his self-efficacy has taken a hit because he got so sick?
So many possibilities.
Exactly. It's such a powerful reminder. Never assume competence based on history alone. You always have to verify learning, especially for critical skills, before they walk out the door.
That's a fantastic point. Okay, and then there was the case study about ML. She's 60, Asian woman, admitted with a COPD exacerbation that's a flare-up of her chronic lung disease. History of COPD, macular degeneration affecting her vision, lives with her daughter and son-in-law who smokes in the house. Ugh. And she cares for grandkids. English is her second language. She feels anxious, no energy.
Yeah, ML's case is like a perfect storm, knitting together almost everything we've talked about. You absolutely cannot plan her teaching in a vacuum.
Right, you have to look at the whole picture.
The whole picture,
Yep.
physically. Macular degeneration means adapting for vision loss. Her shortness of breath, her dyspnea, and anxiety directly impact her readiness to learn. Psychologically, that anxiety, the no energy, huge impact on motivation and focus. Socioculturally, English as a second language means we need a proper medical interpreter. The son-in-law smoking in the house, that's a massive environmental hazard for her COPD that has to be addressed. And her caregiving role for the grandkids adds stress and responsibility.
So many layers.
So many. And then the learner factors. We have to ask her, what does she see as the priority? Maybe it's using her inhalers correctly, understanding her home oxygen. But we also have to tackle that smoking in the house issue, probably very carefully, using motivational interviewing, maybe connecting it to the grandkids' health too. Her case just screams for a truly holistic, patient-centered teaching plan.
Wow. Okay, this has been such a deep dive into patient and caregiver teaching. It really hammers home that it's so much more than just rattling off instructions. It's this complex blend of communication, psychology, clinical knowledge. It's an art and a science.
It really is. And that ability to effectively teach, to truly empower patients, it's absolutely at the heart of what we do as nurses.
Yeah.
I think the core takeaways are pretty clear. Teaching, it's our responsibility. We can't delegate it. It demands a thorough, holistic assessment, patient and caregiver, understanding those adult learning principles, recognizing the stages of change, using techniques like teach back and show back. These are fundamental tools, and remembering that our job doesn't stop at the hospital door. Success often depends on collaborating with caregivers, connecting patients with community resources, ensuring that learning actually translates into lasting health behaviors.
Exactly. So for you, our listener, as you're out there in your practice or getting ready for it, just remember this. The real measure of your teaching, it isn't just what information you delivered, it's what the patient actually learned and what they do with it. Your ability to create that understanding, that confidence, that change, it makes a massive difference in people's lives. And here's maybe something to think about. In this world where everyone is drowning in information, Google searches, conflicting advice, is our main role as nurses maybe shifting? Are we moving beyond just providing information to becoming expert curators and translators of health knowledge, really bridging that gap for our patients in a way that, no algorithm ever could? Food for thought. Thank you so much for joining us for this deep dive. We really hope this gives you a powerful shortcut to feeling well-informed and more confident in your own patient teaching journey. We'll catch you next time.